I'm really glad that you brought up those different perspectives. And so can you elaborate a little more how these are different between, say, a Medicare Advantage or employer-based? I know you have some large employer contracts. How do you build them differently to better suit those particular kinds of arrangements?
The employer-based contracts are unique. It requires a lot of relationship development between the health system, the representatives on that perspective, and the employers, often including consultants that are part of that conversation. You know, a lot of times the quality piece is the same in what we're driving towards, but the employer brings a unique perspective. And there's also additional challenges when you're working with an employer because they have their own unique goals in terms of employee retention, their benefit plan. We may have not as much say in terms of the benefit structure, so you drive patients to the high-performing network and the value-based plan.
Thinking like from a Mercy perspective, roughly what % of patients, I guess from an insurer perspective, we might think covered lives, are in your different value-based and alternative payment models? Is this a small experiment? Is this a large portion of your patients?
So from Mercy's perspective, we are going all in on value-based care. All of our Medicare Advantage patients are in some sort of risk arrangement with us being a very large ACO. And then we are now entering into the space, besides our direct-to-employer contracts, we are entering into risk contracts for commercial carriers as well. So I would say the population size, and you know, I don't have all the stats right on me, but 60+% of our population now sits in some sort of risk contract. And then some of our other large commercial contracts have pay for performance type metrics tied to them.
That was going to be my next question. So there's such an array of arrangements. Can you talk about the balance between the more pay for performance contracts versus something that's really about Mercy managing the total cost of care?
Well, we dipped our toes into probably this type of value-based pay for performance more, in that where we started our journey into this space. And part of it is just wanting to make sure we have all the processes in place, key components like having the right data so that you know who your patients are, and ensuring that your physicians can perform and what resources are needed to support your practicing physicians to ensure that performance. So I think, you know, if you're just starting to get into the space, the pay for performance model gives a little bit of that security, so you're not diving right into risk and writing checks at the end of performance year.
What were the key components as you built your model to ensuring that it would work well for you, for Mercy, for your partners, be they Boeing or others, to building the right model for you?
Number one, I think, is leadership. The leadership has to be fully invested in this type of direction because of the resources that are needed. Finance has to be on board too, because you're changing your source of revenue from a pay for service to, you know, potential risk. And if you're doing it right, you potentially decrease some of that important revenue in a pay for a service, a fee for service type schedule. And so there is a transition period, I think, that does make our finance team a little bit nervous. But beyond that, I think you have to have a robust network of providers that understand this type of work. For Mercy, it's a true investment in primary care, and that knowing that primary care partnership is important. So whether or not a health system owns or employs their providers, you have to work with a group that you're working together. We're fortunate in that as we were going through this process, our leaders identified that primary care would be important to our system and our survival. So for years we have been kind of gathering primary care doctors who perform well. We do a lot of things to help our primary care doctors. Some of it is transparent reporting on various quality metrics. By far, I think most physicians want to perform well and strive to do so. So the bigger challenge is, how do we take away barriers that are preventing them from getting to that quality that we want out of their performance. Sometimes it's simple things like you're clicking the wrong button in the electronic medical record, and so it's not capturing the work you're doing. And I think moving forward, as we go further and further into risk, we need to instill additional support for our doctors to help our patients in between those office visits. And so some of the things we're doing to perform in this area are virtual care, especially for the sickest of the sick. We have a on-call, we call it Mercy on-call services, so our patients have access 24/7. We probably need to start identifying social work, mental health, collaborative care type models to really start getting at, once you take away all the fruit, the low-hanging fruit, you've got to really start driving at some of those higher cost type situations. And there's a lot of it, mental health being one of them.
And that's so different than how most providers or organizations like a Mercy are used to having to operate. I remember it wasn't that long ago, well, mental health, that's over there. Mm-hmm. We do the physical health. Even as we came to understand that they really can't be segregated. What has to happen to get these docs on board to practice differently, because they're so accustomed, right? And you talked about having that mix between the traditional fee-for-service and the new models. So on one hand, aren't you pushing these docs on RVUs, right? Productivity. You got to see more patients. And then at the same time, you're saying, yeah, but we need to manage their holistic health.
Well, we've just changed our compensation model for our physicians. Essentially, after a year of transition, we're no longer on a work RVU productivity model. We are on basically more of a panel size and quality in overall management of the patients. So that's a relief when you come from a provider perspective. It allows us to spend more time with the patient when they need it, or managing the patient in ways that you wouldn't necessarily have to in a work RVU model, which is, I don't need them to come to the office. I just need to understand what their blood pressure is so I can adjust the medication without a full visit. I think that's another big component in these risk and value-based plans, is you've got to have the right compensation model for the providers that are performing in it.
Okay, so you've moved now to panel size for your primary care docs only, I assume. Mm-hmm. Panel size with performance metrics on a host of quality measures. Mm-hmm. Mm-hmm. And then you try to negotiate those quality metrics across all the contracts, so you don't have to balance 50 different sets?
Well, I think for our providers, it'd be great if we could negotiate and have the exact same metrics for everybody across the board. What we did is we just looked at probably the most important metrics, and whether or not it's in one contract or not, but what's going to determine a decrease, what's going to drive the decrease in total spend the most, and really focusing on that. To put 50 metrics out in front of a provider to perform on, that takes them away from their primary focus. So if we can just get them to focus on the most important ones, really the other stuff should fall in line with it.
Sometimes I hear about challenges even on the same kind of metric, let's say A1C testing for your diabetics. Well, this insurer has this standard and another insurer has a different standard, and that could be even within a program like Medicare Advantage. Do you try to get your docs to dig into, well, this patient is on this insurance, so I have to measure them to this standard, and this patient is on a different insurer with a different standard, or did you as a system decide to simplify?
Yeah, I think it's was simplify it for our providers. One, just whatever the metric is that's the most challenging to achieve, that's what we strive for the entire population, right? So if it's an A1C of 8 instead of 9 or 7, that's only going to benefit the entire population. So why not try to drive to that?
Thinking about putting the system in place, what are some key things as far as, you talked about leadership earlier, getting physician leadership or physician champions so that everybody comes on board? Because we know that you don't just decree from on high, dear doctors, you will do this. That doesn't always go well. So how did that work, and how did you make it work well at Mercy?
Years ago, we started with what we call triple aim rounding. It's probably quadruple aim rounding now, and just meeting with each practice on a regular basis to talk to our physicians about the direction we're going, why. We need to understand as physicians why we're going in a certain direction and help build that culture. And that's the opportunity when we're doing those roundings with our clinics to have them give us direct feedback. What's working, what's not working, and how can we improve upon that. We also, as I mentioned, transparent reporting is one way to drive some behavior as well. The compensation model, those types of things.
Thinking about the metrics, you talked about being able to pull things with the EHR and transparently report them. How did you all do that in a way that was satisfactory to those docs?
Initially, there was concern, how are doctors going to feel with this transparent reporting and having everybody's name sort of out there with their performance. At the end of it, it's picking the right metrics too. So it's not every metric, but it's sort of healthy competition. And actually our physicians seem to do quite well with that. I didn't recall hearing any big concerns about you're showing my data to everybody else, and it should be something we're proud about as a physician. And also the understanding that if somebody's not performing well, it doesn't mean they're not a good performer. Often it's blood pressure. Are their MAs trained appropriately to take a good accurate blood pressure? And so we did spend a lot of that time re-educating various practices to ensure the patient's sitting for 5 minutes and they're in a rested position, and all those different things that are important when taking a blood pressure. So then it helps us identify where challenges are, and then we can go back and work with the physician and the practice to overcome whatever barriers are preventing that quality from shining through.
So I'm messing up my doctor's metrics when I rush into my consult and the MA throws the cuff on me right away. Good to know. I'll be more patient. So you didn't have issues as far as convincing docs that these were evidence-based guidelines and they should be on board. They were already bought in.
Yeah. I mean, I can't think of a metric that has been pushed back by our providers because they thought it wasn't of value. I mean, and that's part of what the quality team job is, to make sure we're presenting and picking the right metrics to measure. And my job as the primary care leader for our doctors, if they're pushing back, I need to spend some time educating them on the why. And ultimately, they might not be a great fit for Mercy if they're not buying into some of these well-studied metrics that need to be followed.
So does that mean that the risk-bearing arrangement extends to the hospital? Or are they still on fee-for-service, DRGs or whatever?
For mostly the hospital services are still on DRGs, but looking into bundled payments, many employers have come to us saying they want certain services kind of bundled together, or center of excellence kind of location for Mercy to be an employer's choice. So those conversations occur, and it's a matter of just pulling those folks that are in charge of those service lines in to ensure that, is this something we want to do? Is this something that we're ready to do? Some service lines are a lot easier to do that than others, hips and knees and that being one of them.
So what does that look like? Are those like super DRGs where you're just adding upstream and downstream services to a traditional DRG? How do you accomplish that?
Well, so that's a little bit beyond kind of what my experience has been, but as employers have brought it, they want us to sort of say, okay, we're willing to pay a little bit more for a knee procedure to get quality, but if you have a complication, we're not giving you any extra on top of that. So it's really intended to bundle in all of the potential complications and aftercare and all that stuff. I don't know if I answered your question exactly.
To a degree, what I'm hearing, if I heard you right, I heard that the hospital sounds like it's still relatively a traditional payment, however, with kind of some curbs and some guarantees that added security, maybe, value to the insurer, to the insurer or the employer.
As a system, as a whole, I mean, the bottom line's the bottom line, and if we're not performing in our risk contract and we're having to write a check at the end of the day, that impacts the whole system. If you have alignment, whether it's, bonus structures for your leaders who are across the board, if you perform in one area, then everybody succeeds.
You talked about paying doctors differently. So what is the secret? How do you pay docs differently so that this works?
Well, the incentives and the compensation model need to be aligned. So a work productivity, work RVU model that just incentivizes the providers to bring patients to the office doesn't work in this model. You need to incentivize your providers to focus on things like ER utilization and driving that down. So maybe that means you have more access on your templates, and so you're not booked out for 6 months and then by default telling patients to go to the emergency room or urgent care because there's just no more time on your template. And I think it's also expanding primary care in a way that we have to think differently, using our APPs in a more effective way to help our providers manage in a primary care setting.
Since you brought up the APPs, like roughly what percent of your personnel have you migrated to an APP rather than traditional physicians?
We are more and more recruiting APPs, and in fact, some of our doctors are retiring or transitioning onto a different job or things. And in the conversations I'm having with practices is, do we need to replace the physician with an APP? Because it takes a while to recruit a physician. And by the time you get a physician to replace it, you want to make sure you haven't lost a few patients along the way.
And historically, you had to be concerned, is that a practitioner whom in my state is billable?
Mm-hmm.
But now it sounds like you don't need to worry about that at all.
Right, yeah.
So whomever can meet that. Has that caused you to develop teams that have all kinds of allied health nutritionists? So you mentioned social workers. To what extent are you building teams to deal with health rather than only traditional?
Our teams right now predominantly are within each clinic. So it's the providers, the medical assistants, some nurses, and then we have care management nurses that support, not necessarily within the practice. Then you add the entire population health team that virtually helps us manage the patient in between. So starting to use technology, digital apps, which can check on patients who have congestive heart failure. Have you gained weight today? Are you more short of breath? And then if they are answering yes to one of those questions, then immediately somebody's calling them. Our Mercy Nurse on Call services, the data team, I would include them as part of the healthcare team because we need somebody that can help find those patients who have a gap in care or who are overdue for an annual wellness visit, and how do we reach out and grab those. So we're using a digital approach to help with those. Now, I think our next phase, though, is, and we've started in this area, is the community health workers, the mental health social worker for the collaborative care. We've always had dietitians and diabetic educators as part of our team, although not physically in each practice location.
Back to compensation, does that make a clinic look like they're essentially capitated because we have this big of a panel and you work that out? Are docs capitated or salary productivity? These are all models I've heard of.
It's probably more like a little bit more like a capitated model from our physician's perspective. So you're not getting paid by the number of visits a patient is seen. You're really getting paid by the overall management of the patient, whether you see them 6 times in a year or once. And then, working with your APP as part of that team and that panel management or your other providers within the clinic. Another thing that I think is helpful moving forward is kind of thinking about primary care hubs, where in a system like ours, and we're so interconnected, you can sort of combine different hubs together, different clinics together into one hub, and share services, share RN, share the social workers, and potentially offer sort of non-traditional access hours, like weekends and evenings, and share sort of those resources.
What kind of clinics are we talking about? Primary care and endocrinology then, because we've got diabetics and we've got some ophthalmology, or just adjacent primary care?
More, I was referring to adjacent primary care. We have also employed APPs who specialize sort of in diabetes as the primary care, within the primary care team. So they're working with our primary care providers to help us manage patients who have diabetes across the system, because we kind of reserve those really more difficult or brittle controlled diabetic patients for the endocrinologist. Otherwise, they're 6 months to get in with an endocrinologist, and maybe, that's an unnecessary use of a resource when we can spend a little bit more time with the patient to manage their care.
Sounds like you've got some kind of capitated or quasi-capitated sort of arrangement for the physicians. So that's kind of a fixed thing. Now, eons ago, criticisms of capitation included, oh, well, there will be withholding of care. So do you have some kind of incentives, disincentives, carrots and sticks to help ensure that they're doing everything they need to be for the amount they've already been paid?
Right now, our physicians are not penalized because of overutilization of ordering echocardiograms or something like that, or MRIs. It's not a direct tie to the total cost of care for each patient. So the physicians don't really carry that risk. What they have risk in, and which I think will drive performance is the quality metrics that are tied to compensation. So if you withhold care, your quality metrics will go down. And as a result, your compensation will go down. So I think you got to have the right balance, and there's enough weight on the quality metrics that are in place that it's really important to the provider to do both, grow your panel and pay attention to these metrics, because there's a decent financial impact.
So carrots, sticks, or both for your
I think
incentive?
It's both. Yeah, I think it's both.
Can you give an example of how you use them in the two different ways and why?
Just in the comp model itself, if you perform really well, you get paid more, but if you're not performing, the compensation dip can be substantially different. So I think in a sense that's sort of both a carrot and a stick because of the difference in your performance and what your compensation will end up with. Our sticks would be, our transparent reporting. I can see, and any physician can see, how another physician is performing in the compensation, not the compensation model, but in the quality metrics. And therefore, that's kind of a stick too. Like, I want to do better because it's public knowledge.
So if I fail to meet my metrics as one of your docs, I'm just not going to get bonuses, or it actually decreases my comp?
It decreases your comp.
It's just an area of behavioral economics that I think is fascinating, about whether you, even on paper only, give people the compensation in advance and in their minds they're losing, or whether they're building up from a level.
Yeah.
Studies show it matters. It sounds like you go both directions with it.
You look at kind of the expected performance, I'll say, of if you are just kind of performing average, you make a certain amount for that quality perspective, and then you can go down from there. So that's where I think you get at.
But also up.
But also up, yeah. We before this model, we have quality metrics that were added compensation if you performed. So it was like, great job, here's an additional, amount on your paycheck. Before this model, we have quality metrics that were added compensation if you performed. So it was like, great job, here's an additional amount on your paycheck. And if you didn't perform, it just kind of would go away. Doctors notice pretty quickly.
So it's not just 5 or 10%, it can be a lot more.
Right.